Welcome to Pediatric Case Review, Musculoskeletal Series. Today we present a comprehensive case-based clinical review on skeletal dysplasias, designed for pediatric physicians and trainees. This lecture covers 14 carefully crafted clinical cases exploring clinical presentation, pathophysiology, radiographic findings, genetic mechanisms, diagnostic workup, and both medical and surgical management of the most important skeletal dysplasias. Whether you are preparing for exams or refining your clinical skills, this lecture will sharpen your diagnostic approach. Let us begin. Case 1. A 4-month-old infant boy is brought to the clinic by his parents due to concern about his appearance and growth. The mother reports he has a noticeably large head and very short arms and legs compared to his body. On examination, the infant has a prominent forehead with frontal bossing, a flat nasal bridge, and mid-face retrusion. His limbs are short, particularly at the proximal segments, meaning the upper arms and thighs. His fingers are short and appear to diverge in a characteristic pattern. Radiographs show rhizomelic shortening of the long bones, square iliac wings, and a narrow sacroiliac notch. What is the most likely diagnosis? Option A, Osteogenesis imperfecta. Option B, Achondroplasia. Option C, multiple epiphyseal dysplasia. Option D, Thanatophoric dysplasia. The correct answer is Option B, Achondroplasia. This infant presents with the classic triad of achondroplasia: rhizomelic limb shortening, meaning the proximal segments are disproportionately shortened, macrocephaly with frontal bossing and mid-face retrusion, and the Trident hand configuration. The pelvic radiograph confirms square iliac wings in a narrow sacroiliac notch, which are pathognomonic pelvic findings. Achondroplasia is caused by a gain-of-function mutation in the fibroblast growth factor receptor 3 gene, most commonly the C.1138G greater than a variant, resulting in constitutive receptor activation and impaired chondrocyte proliferation at the growth plate. Molecular testing of the fibroblast growth factor receptor 3 gene confirms the diagnosis. Case 2. A 3-year-old girl is brought to the clinic by her parents after sustaining her 4th fracture in the past 18 months, all resulting from minor household falls. Her parents deny any significant trauma. On examination, she has a triangular-shaped face, and the whites of her eyes appear distinctly bluish in color. Her teeth appear translucent and brownish. She is at the 5th percentile for height and weight. Radiographs reveal generalized osteopenia, thin cortices, and multiple healed fractures in various stages of healing. What is the most likely diagnosis in this child? Option A, rickets. Option B, hypophosphatasia. Option C, osteogenesis imperfecta. Option D, child abuse. The correct answer is Option C, osteogenesis imperfecta. The classic triad of recurrent fractures from minimal trauma, blue sclerae, and dysgenesis imperfecta points clearly to osteogenesis imperfecta. This condition results from mutations in the COL1A1 or COL1A2 genes, leading to defective type 1 collagen production. Blue sclerae occur because thin scleral collagen allows the underlying choroid vasculature to show through. Dysgenesis imperfecta produces opalescent, brittle teeth due to defective dentin matrix. Radiographically, Wormian bones on skull X-ray, defined as more than 10 Wormian bones each larger than 6 mm, are a hallmark finding. Normal serum calcium, phosphate, and alkaline phosphatase levels distinguish osteogenesis imperfecta from rickets and hypophosphatasia. The most common inheritance is autosomal dominant. Case 3. A 7-year-old boy presents with a 6-month history of progressive bilateral hip and knee pain, worse after physical activity. His parents note he has developed an unusual waddling gait over the past few months. On examination, height is at the lower limit of normal for age. Bilateral hip stiffness with reduced internal rotation is noted. Mild genu valgum is present. No significant limb length discrepancy. Gait is waddling. Plain radiographs of the hips and knees show irregular, flattened epiphyses bilaterally with no significant metaphyseal changes. Spine X-ray is unremarkable. Select the most likely diagnosis. Option A, multiple epiphyseal dysplasia. Option B, leg calf Pertus disease. Option C, spondyloepiphyseal dysplasia. Option D, achondroplasia. The correct answer is Option A, multiple epiphyseal dysplasia. This 7-year-old presents with the classic pattern of multiple epiphyseal dysplasia: progressive bilateral joint pain, waddling gait, and bilateral irregular flattened epiphyses without significant metaphyseal or spinal involvement. Key radiographic hallmarks include the glacier crevice sign at the distal femoral epiphyses and the harlequin hat appearance on lateral knee X-ray in M18-3 related multiple epiphyseal dysplasia. Multiple epiphyseal dysplasia is caused by variants in cartilage extracellular matrix protein genes including COMP, MATN3, COL9A1, COL9A2, COL9A3, and SLC26A2. It can mimic Pertus disease, but bilateral symmetric involvement and knee epiphyseal changes help differentiate. Leg calf Pertus disease is typically unilateral avascular necrosis of the femoral head. Achondroplasia presents with rhizomelic shortening and macrocephaly, which are absent here. Case 4. A 3-year-old boy is brought to the pediatric clinic by his parents for a routine developmental assessment. His parents note that he has always had shorter arms and legs compared to other children his age. On physical examination, the child has a large head with a prominent forehead, a flat nasal bridge, and midface protrusion. His limbs are noticeably short, especially the upper arms and thighs. The examining physician is assessing for the characteristic hand finding associated with this condition. Which of the following physical examination findings is considered a hallmark feature of achondroplasia? Option A, blue sclerae. Option B, saber shins. Option C, genu valgum. Option D, Trident hand configuration. The correct answer is option D, Trident hand configuration. The Trident hand is a pathognomonic sign of achondroplasia. It is characterized by brachydactyly with shortened fingers and thumbs, finger divergence meaning separation between the middle and ring fingers, inability to approximate fingers when making a fist, and short broad hands with a stubby appearance. This hand pattern results from disproportionate growth of metacarpals and phalanges due to fibroblast growth factor receptor 3 mutations affecting cartilage development in the growth plates. Blue sclerae are associated with osteogenesis imperfecta, not achondroplasia. Saber shins are seen in congenital syphilis and Paget disease. The classic diagnostic triad for achondroplasia in infancy combines the Trident hand, rhizomelic limb shortening, and characteristic facial features. Case 5. A newborn male is delivered at 36 weeks gestation following a pregnancy complicated by polyhydramnios. On examination, the neonate has extremely short limbs affecting all segments, a markedly narrow chest, and a distinctive skull deformity with 3 prominent bulges. Chest X-ray reveals very short, horizontally oriented ribs. Skeletal radiographs show severe micromelia with telephone receiver-shaped femurs and platyspondyly. The infant develops severe respiratory distress immediately after birth. What is the most likely diagnosis? Option A, achondroplasia. Option B, thanatophoric dysplasia. Option C, osteogenesis imperfecta type 2. Option D, cleidocranial dysplasia. The correct answer is option B, thanatophoric dysplasia. Thanatophoric dysplasia is the most common lethal skeletal dysplasia. The word thanatophoric means death-bringing in Greek. The hallmark features are severe micromelia affecting all limb segments, a critically narrow thorax causing respiratory failure at birth, platyspondyly meaning severely flattened vertebral bodies, and telephone receiver-shaped femurs on X-ray. Type 2 thanatophoric dysplasia is further distinguished by the cloverleaf skull deformity, also called Kleeblattstudel, which is a trilobed cranial deformity. It is caused by a gain-of-function mutation in the fibroblast growth factor receptor 3 gene, specifically K650E in type 1 and R248C in type 2. Distinct from the G380 are mutations seen in achondroplasia. Unlike achondroplasia, which is non-lethal, thanatophoric dysplasia leads to perinatal death due to respiratory failure from thoracic restriction. Case 6. A research team is investigating the molecular basis of achondroplasia. They discover that affected patients have a specific mutation in the fibroblast growth factor receptor 3 gene, designated C.1138G greater than A, that results in a glycine to arginine substitution at position 380 in the transmembrane domain. This mutation causes the receptor to become constitutively active, leading to continuous inhibition of chondrocyte proliferation in growth plates, even without ligand binding. What is the molecular mechanism underlying this pathophysiology? Option A, loss of function mutation leading to reduced receptor activity. Option B, haploinsufficiency causing developmental delays. Option C, gain of function mutation causing constitutive receptor activation. Option D, dominant negative effect disrupting normal protein function. The correct answer is option C, gain of function mutation causing constitutive receptor activation. In achondroplasia, the gain of function mutation in fibroblast growth factor receptor 3, most commonly C.1138G greater than A, causes the receptor to signal continuously without requiring fibroblast growth factor ligand binding. This constitutive activation leads to reduced chondrocyte proliferation in the growth plate, reduced chondrocyte differentiation and hypertrophy, and ultimately reduced longitudinal bone growth, especially in proximal limbs. The mutation causes a glycine to arginine substitution in the transmembrane domain, promoting receptor dimerization independent of fibroblast growth factor ligand. This is the opposite of a loss-of-function mutation. More signaling equals less bone growth. Importantly, gain-of-function mutations in fibroblast growth factor receptor 3 also cause hypochondroplasia, which is milder, and thanatophoric dysplasia, which is lethal, representing a spectrum based on mutation location and severity. Case 7. A 2-year-old girl is brought to the clinic by her parents due to concern about frequent fractures. She has sustained 4 fractures over the past 18 months, all from minimal trauma such as rolling off a couch. On examination, she has a triangular-shaped face, short stature for her age, and her sclerae appeared distinctly blue. Dental examination reveals small, yellowish-brown, translucent teeth. A skeletal survey shows generalized reduced bone density, thin cortical bone, and multiple Wormian bones on the skull X-ray. Her serum calcium, phosphate, and alkaline phosphatase levels are all within normal limits. Mutations in the COL1A1 or COL1A2 genes are the primary genetic cause of which of the following conditions? Option A, Marfan syndrome. Option B, Ehlers-Danlos syndrome. Option C, hypophosphatasia. Option D, osteogenesis imperfecta. The correct answer is option D, osteogenesis imperfecta. COL1A1 and COL1A2 are the genes encoding the alpha-1 and alpha-2 chains of type 1 collagen. Mutations impair the triple helix structure of collagen, leading to collagen misfolding and degradation, defective osteoid formation, decreased bone mineralization, and increased bone fragility. The osteogenesis imperfecta classification includes 4 main types. Type 1 is mild with blue sclerae and few fractures caused by COL1A1 haploinsufficiency. Type 2 is lethal in the perinatal period with severe micromelia. Type 3 is severe with progressive deformity. Type 4 is moderate with normal sclerae. The key differentiator in this case is that serum calcium, phosphate, and alkaline phosphatase are all normal, ruling out rickets and metabolic bone disease. Marfan syndrome involves fibrillin 1 mutations. Ehlers-Danlos syndrome involves multiple collagen and matrix proteins, but not primarily COL1A1 or COL1A2 in the classic form. Hypophosphatasia involves alkaline phosphatase gene mutations with low alkaline phosphatase levels. Case 8. A 3-year-old girl is referred to the Pediatric Genetics Clinic for evaluation of disproportionate short stature. Her parents report that she has always had shorter limbs compared to her peers. On examination, she has rhizomelic limb shortening, macrocephaly with frontal bossing, midface protrusion, and a trident hand configuration. Her growth parameters show height well below the 3rd percentile. No fractures have been reported. The pediatrician suspects a skeletal dysplasia and wishes to proceed with the most appropriate imaging evaluation to characterize the bony abnormalities comprehensively. What is the most appropriate initial imaging investigation for this child? Option A, complete skeletal survey. Option B, targeted magnetic resonance imaging of the spine. Option C, ultrasound of long bones only. Option D, radionuclide bone scan. The correct answer is option A, complete skeletal survey. A complete skeletal survey is the essential first-line imaging investigation whenever a skeletal dysplasia is suspected. It systematically evaluates multiple regions to reveal characteristic radiographic patterns, enabling accurate classification and guiding targeted genetic testing. The required views include skull anteroposterior and lateral to look for Wormian bones, macrocephaly, and cloverleaf deformity. Spine anteroposterior and lateral to identify platyspondyle, bullet-shaped vertebrae, and scoliosis. Chest and ribs anteroposterior to assess for short ribs and narrow thorax. Pelvis anteroposterior for square ilia and narrow sacroiliac notch. Long bones bilateral for rhizomelic or mesomelic shortening and cortical thickness. Hands and feet bilateral for trident hand, brachydactyly, and epiphyseal irregularity. Knee anteroposterior and lateral for epiphyseal dysplasia and harlequin hat sign. In suspected osteogenesis imperfecta, always include the skull series to identify Wormian bones. Case 9. A 2-year-old child presents with a history of recurrent fractures from minimal trauma. Physical examination reveals blue sclerae and hearing difficulties. Initial radiographs show generalized osteopenia and thin cortices. Serum alkaline phosphatase levels are normal, and a previous skin biopsy for collagen analysis showed inconclusive results. The clinical team suspects recessive osteogenesis imperfecta and needs definitive diagnostic confirmation. Which of the following tests would provide the most definitive diagnosis for this patient? Option A, serum calcium and phosphate levels. Option B, molecular genetic testing using whole exome sequencing. Option C, repeat skin biopsy for collagen analysis. Option D, bone biopsy with histological examination. The correct answer is option B, molecular genetic testing using whole exome sequencing. Whole exome sequencing is the gold standard confirmatory tool when clinical and biochemical findings suggest a skeletal dysplasia, but initial testing is inconclusive. In recessive osteogenesis imperfecta, mutations are found in genes like CRTAP and LEPR1, which encode proteins essential for post-translational modification of type 1 collagen. Targeted gene panels including COL1A1, COL1A2, CRTAP, LEPR1, and PPIB offer a faster cost-effective first step when osteogenesis imperfecta is strongly suspected. Skin biopsy for collagen analysis may be normal in recessive osteogenesis imperfecta forms, making it unreliable as a standalone test in atypical presentations. Whole exome sequencing captures both known and novel variants, making it ideal for cases that do not respond to standard diagnostic pathways. In recessive osteogenesis imperfecta, CRTP and LEPR1 mutations disrupt 3-hydroxylation of proline in the collagen triple helix, causing severe bone fragility even when COL1A1 and COL1A2 are structurally intact. Case 10. A 6-year-old boy is diagnosed with achondroplasia confirmed by molecular genetic testing showing a pathogenic fibroblast growth factor receptor 3 variant. His current height is significantly below the 3rd percentile for age. His parents are concerned about his growth and ask about available pharmacological options. His pediatric endocrinologist discusses a recently approved medication specifically targeting the underlying molecular pathway responsible for reduced growth in achondroplasia. Which of the following is the first approved pharmacological treatment specifically indicated to increase growth velocity in children with achondroplasia? Option A, growth hormone. Option B, bisphosphonates. Option C, vosoritide. Option D, denosumab. The correct answer is option C, vosoritide. Vosoritide is a C-type natriuretic peptide analog and the first drug approved by both the United States Food and Drug Administration and the European Medicines Agency specifically for achondroplasia. It acts by antagonizing the overactive fibroblast growth factor receptor 3 signaling pathway, binding the natriuretic peptide receptor B, increasing cyclic guanosine monophosphate signaling, and thereby restoring normal chondrocyte proliferation in the growth plate. Clinical trials demonstrated an increase of 1.6 to 1.9 centimeters per year in annualized growth velocity in children aged 5 to 18 years. It is administered as a daily subcutaneous injection at 15 micrograms per kilogram per day and is well tolerated with minimal systemic side effects. Growth hormone is not effective in achondroplasia because the fibroblast growth factor receptor 3 pathway is independent of the growth hormone axis. Bisphosphonates are used in osteogenesis imperfecta for bone fragility, not in achondroplasia. Monitoring includes growth velocity, safety labs, and spine imaging every 6 to 12 months. Case 11. A 4-year-old girl is brought to clinic with a history of 7 fractures since birth, occurring from minimal trauma such as rolling in bed. Her mother reports she cries frequently with routine handling. On examination, she has blue sclerae, opalescent teeth, mild limb bowing, and generalized muscle hypotonia. Her height is below the 3rd percentile. Radiographs show generalized osteopenia, thin cortices, multiple healing fractures, and Wormian bones on skull X-ray. Serum calcium and phosphate are within normal limits. A diagnosis of severe osteogenesis imperfecta type 3 is confirmed on genetic testing. What is the standard medical treatment to reduce fracture frequency and improve bone density in this child? Option A, vitamin D supplementation. Option B, calcium supplementation. Option C, calcitonin injections. Option D, intravenous bisphosphonates. The correct answer is option D, intravenous bisphosphonates, specifically pamidronate. Intravenous pamidronate is the standard of care for moderate to severe osteogenesis imperfecta in children. It works by inhibiting osteoclast-mediated bone resorption, increasing bone mineral density, and reducing fracture frequency by up to 60% over 18 months. The dosing protocol for pamidronate disodium is as follows. Children under 2 years receive 0.5 milligrams per kilogram per cycle. Children aged 2 to 3 years receive 0.75 milligrams per kilogram per cycle. Children over 3 years receive 1.0 milligrams per kilogram per cycle. Infusions are given every 3 to 4 months over 3 consecutive days per cycle. Bone mineral density improvement at the lumbar spine ranges from plus 35 to plus 50% on Z-score. Annual fracture rates decrease by approximately 40 to 60%. The most common side effect is an acute phase reaction with fever and myalgia during the first infusion. Monitoring includes serum calcium, phosphate, and renal function. Case 12. A 10-year-old boy with a confirmed diagnosis of achondroplasia is referred to the orthopedic clinic. His parents report that over the past 18 months, he has developed an increasingly noticeable inward bowing of both knees. On examination, he has bilateral progressive genu valgum with a measurable intermalleolar distance. He has no neurological deficits and walks with a waddling gait. Standing lower limb radiographs confirm progressive bilateral valgus deformity of the knees with open growth plates. His bone age is consistent with his chronological age. Which of the following is the most appropriate surgical intervention for this patient? Option A, guided growth with 8 plates. Option B, acute corrective osteotomy. Option C, amputation of the affected limb. Option D, external fixation with gradual correction. The correct answer is option A, guided growth with 8-plate implants. Guided growth using 8-plate implants is the gold standard for correcting angular limb deformities in growing children with skeletal dysplasias. This minimally invasive technique allows gradual correction through controlled growth modulation, avoiding the need for complex osteotomies in most cases. The key benefits include preservation of joint anatomy, gradual and natural correction. It is a reversible procedure, and it involves minimal surgical trauma. The 8-plate is placed on the convex side of the deformity at the distal femur or proximal tibia, tethering growth on that side, while the opposite side continues to grow, gradually straightening the limb alignment over time. Correction typically occurs over 12 to 18 months, with implant removal after the desired alignment is achieved. Success rates exceed 85% for moderate deformities. Acute osteotomy is reserved for severe deformities in skeletally mature patients where guided growth is no longer possible. Case 13. A 35-year-old male with a known history of achondroplasia presents with a 6-month history of progressive bilateral leg pain, numbness, and weakness, worsened by walking and prolonged standing. He also reports episodes of urinary urgency. On examination, lower extremity hyperreflexia is noted. Magnetic resonance imaging of the lumbar spine reveals significant canal narrowing at lumbar vertebrae 3 to 4 with evidence of cord compression. What is the most appropriate initial management for this patient? Option A, physical therapy and pain management. Option B, oral corticosteroids and muscle relaxants. Option C, surgical laminectomy and decompression. Option D, bed rest and activity modification. The correct answer is option C, surgical laminectomy and decompression. Achondroplasia causes progressive spinal canal narrowing due to shortened pedicles, thickened laminae, and hypertrophied ligamentum flavum. Lumbar stenosis affects more than 90% of adults with achondroplasia by the 8th decade of life. Neurogenic claudication, meaning bilateral leg pain, numbness, and weakness worsened by walking, is the hallmark presentation. In this patient, hyperreflexia and urinary urgency indicates significant cord and cauda equina involvement requiring urgent surgical evaluation. Conservative therapy such as physical therapy and bracing is only appropriate for mild, non-progressive symptoms. Surgical laminectomy and decompression is the treatment of choice for progressive neurological deficits and magnetic resonance imaging confirmed cord compression. Early surgical intervention is associated with significantly better long-term functional outcomes. Delay risks irreversible neurological damage, making timely surgical referral essential in this clinical scenario. Case 14. A 3-month-old infant with known achondroplasia is brought for a routine developmental follow-up. The parents report that the baby has been unusually irritable, feeding poorly, and showing decreased spontaneous limb movements over the past 2 weeks. On examination, the infant has a large head circumference above the 98th percentile with a bulging anterior fontanelle. Tone is reduced in all 4 limbs. Neurological assessment reveals hyperreflexia in the lower extremities. Which of the following complications requires close monitoring and urgent evaluation in this infant? Option A, hydrocephalus only. Option B, foramen magnum stenosis. Option C, retinal detachment. Option D, renal failure. The correct answer is option B, foramen magnum stenosis. In achondroplasia, the foramen magnum is abnormally small due to restricted skull base growth from premature synchondrosis fusion. This narrowing compresses the cervicomedullary junction, endangering the brainstem and upper cervical spinal cord. In infants, this compression is the leading cause of sudden unexpected death in achondroplasia, occurring in up to 7.5% of untreated cases. Clinical warning signs include central sleep apnea and irregular breathing patterns, hypotonia and poor head control, hyperreflexia or clonus in lower limbs, and feeding difficulties with failure to thrive. Magnetic resonance imaging of the brain and cervical spine is the gold standard imaging modality showing cord signal change or cervicomedullary compression. Polysomnography, meaning a sleep study, is recommended in all infants with achondroplasia to detect central apnea events. All infants with achondroplasia should undergo magnetic resonance imaging of the craniocervical junction and a sleep study within the first 6 months of life, regardless of whether symptoms are present. Neurosurgical decompression by suboccipital craniectomy and C1 laminectomy is indicated when magnetic resonance imaging shows cord compression or polysomnography reveals significant central apnea. We want to take a moment to tell you about our exclusive learning community, Pediatric Case Review, on Patreon. This community is your all-in-one hub for pediatric clinical education. All videos are organized by body system, including musculoskeletal, neurology, cardiology, and more, so you can find exactly what you need instantly. All presentation slides used in the videos are also available as high-resolution photo downloads, so you can read, annotate, and practice every question at your own pace. You can reinforce your knowledge with every case-based multiple-choice question from our lectures and review anytime, anywhere. If you would like to join and learn more about how to subscribe, simply comment below in this post, and we will personally message you with all the details you need. And that brings us to the end of today's lecture on skeletal dysplasias. We explored the clinical presentation, pathophysiology, diagnostic workup, and management of the major skeletal dysplasias through 14 evidence-based clinical cases. We hope this lecture has sharpened your diagnostic skills and deepened your clinical understanding of these important conditions. If you found this lecture useful, please follow and subscribe to Pediatric Case Review for more informative, case-based presentations on pediatric topics. New musculoskeletal and pediatric disorder lectures are on the way, so stay connected. If you have any questions about today's cases, or if there is a topic you would like us to cover in a future lecture, please drop your comment below. We read and respond to every comment. Stay curious, stay informed, and keep improving patient care.